Good day, colleagues. My name is Dr. Arapeli and welcome to my presentation titled Tackling Acute Malnutrition Through Community-Driven Solutions. My name is Dr. Puswani Katse, project lead. Originally, I'm from Botswana, and I work as a public health physician as well as a health emergency preparedness, response, and resilience consultant with the World Bank. I also run my own private medical clinic, Bespoke MediCenter, which is a community-centered clinic that aims at making private care more affordable. The project brief stems from my love for acute malnutrition and ensuring that it does not affect as many children as it currently does, because nutrition is a basic human right. I currently live and work in Bodeti district, which currently has a malnutrition average of 5.6%. This far exceeds the national target of 3.2%, highlighting the urgent need to deal with this problem. Communities are at the center of everything we do, which is why this is a community-centered project. And I would like to have the community involved so that they could have more sustainable solutions to the modern malnutrition issue. What is this project about? This project is targeting at children aged 6 to 59 months in the district, where we find the most of the children that are affected by acute malnutrition and hospitalized. We aim to come up with community interventions, which include direct feeding programs solely led by the community, nutrition education, and household gardening for sustainability. As I had said before, according to the Botswana National Nutrition Survey, the current rate is 5.6%, and we would like to reduce it to less than that. The effects of malnutrition are long-standing and ultimately cause infections, stunting, as well as developmental challenges for children as they get older. We would therefore like to address this health inequity as well as break the cycle of poverty, which is one of the key causes of acute malnutrition. And to do this, we want to have sustainable community-led solutions. Some of the solutions we've come up with is the direct feeding program, which is led by the mothers and the caregivers within the communities that we live in. We also have pediatric screening because, like I had said, most of the children would have infections. We also have community gardens, which help ensure that children have the proper nutrition even at home. And we give nutrition classes to the mothers and educate the children as they're there every day. These interventions are mainly targeted towards caregivers, healthcare workers, as well as the ministries that we work with, like the Ministry of Health and Ministry of Local Government. The challenges we have seen is these communities are highly mobile. We're therefore not able to give interventions to children every month, but we do try to do outreaches so that we can reach them. We also have realized that there is quite a lot of alcohol abuse, which leads to a lot of child negligence. We therefore have to do a lot of home visits to collect the children. The society that we work with is also living below the poverty datum line, which means there are resource constraints that we have to deal with. The opportunities we have currently are we work with a lot of local leadership, which is strong and would like to see the program succeed. Also, we have collaborations with the private partners who are supporting with food and other things that we might need. So far, we've been able to reduce the malnutrition rate to 4.6% within the first year of implementation, and we hope to further reduce it. And this is on the 187 children that we have screened versus the 263 that we have identified. We anticipate to have a little bit more than this. We are currently doing monthly screening data to show how many children we've screened. We're also doing recovery rates because we want to see how many kids are discharged successfully and do not come back, as well as seeing if our feedback or whatever we're doing is being received well by doing focus groups. We intend to scale the project up by having a nutrition rehabilitation center in the first quarter of next year, as well as expanding it to other villages. We also want to engage local mining companies to support with resources, as well as establishing long partnerships with the existing health systems that we have. We also want now the community to own up and be able to capacitate and take the projects up on their own. Personally, as a closing message, I've been able to embody 4 leadership pillars: authentic leadership, inclusive leadership, strategic leadership, impactful leadership, all of which were very important to me because I stayed true to myself. I made sure that the community that I'm working with was listened to and voiced their opinions, as well as ensuring that the decisions that we make have a scientific impact to them or a public health knowledge to them. I would like to go on and say this was an adaptive leadership and system thinking process for me because I was able to unite two things that I really like, my passion for public health and community, to come up with solutions. And I wish to scale up this project to other villages and make sure that it has a strong impact. And for that to happen, I will still have to strengthen my partnerships with both government and private sectors. Thank you.